Are you able to share, Mandy, or?
I don't have, so I think Amanda, I don't have the intro slides.
Okay. I will get started without the intro slides then. So sorry everybody for our delay today. First of all, we want to say hello and welcome everyone to Grand Rounds for the Minnesota Regional Spinal Cord Injury Model System, or as we call MINSCIMS for short. And thank you all for joining us today. MINSCIMS is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research, or NIDLR, to support innovative projects and research in the delivery, demonstration, and evaluation of medical, rehabilitation, vocational, and other services to meet the needs of individuals with spinal cord injury. The MINSCIMS represents an exciting new partnership among the following Minnesota institutions: Courage Kenny Rehabilitation Institute in Minneapolis, Mayo Clinic in Rochester, Regents Hospital in St. Paul, and the University of Minnesota in Minneapolis. Our community collaborators include Minnesota Spinal Cord Injury Association, Unite to Fight Paralysis, Get Up, Stand Up to Cure Paralysis, the Paralyzed Veterans of America, United Spinal Association, and the North American Spinal Cord Injury Consortium. This system collectively provides a multidisciplinary continuum of care for people with spinal cord injury, including emergency medical care, acute rehabilitation, and post-acute services. My name is Dr. Kimberly Mondin, and I will be the moderator of today's session. I'm an assistant professor in the Department of Rehabilitation Medicine at the University of Minnesota Medical School, and I'm co-project director of the MINSCIMS with Dr. Leslie Morse. A few housekeeping notes for today. So the University of Minnesota has organized the CME for today's webinar. Please see the chat for information on how to record your attendance and claim CME credit for attending this webinar within 24 hours of the event. This meeting is being recorded and will be posted on the MINSCIMS website. To earn CME credit for today's presentation, please click on the link in the chat. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we welcome and encourage audience participation using the chat and Q&A functions. If you have technical or logistical questions, we ask that you submit those in the chat to Dan Kelly, who will be monitoring the chat. The title of today's presentation is Osteopathic Manipulative Treatment, OMT, to optimize pain and alignment for improvement of function and quality of life in individuals with SCI. The speaker for today's webinar is Dr. Amanda Miller. Dr. Miller is a double-boarded PM&R and spinal cord injury medicine physician. She currently practices at the Courage Kenny Rehabilitation Institute in Golden Valley in both the outpatient and transitional rehab program setting. She has been practicing OMT for the last 10 years as part of a holistic approach to patient care. She's also a part of the MINSCIMS. Dr. Miller, welcome and thank you for presenting today. And I will hand it over to you to share your slides.
Okay. All right, in the slide view. Oh. All right. I just want to say thank you, everyone, for joining me today. I'm pretty passionate about OMT, and I'm very excited to get to use it on so many of my patients with spinal cord injury. So thank you for joining me for my last day in my 30s to discuss my favorite topic. This is my dog, Ruby Sue. She's ready for her OMT treatment. So a small disclaimer. I'm going to talk about techniques and show you images of how to perform them, but they really are intended for educational purposes only and should only be performed by licensed DOs. Now, I think I have to start at the beginning a little bit because I don't know who all is on our call. So in the United States, there's two different ways that you can go to medical school. One is to become an allopathic doctor, which is known as an MD, and the other is to become a DO, or osteopathic doctor. We are trained with certain principles, and those are listed here. And the reason I wanted to discuss this is these principles drive how and why we perform OMT, or osteopathic manipulative treatment, for our patients, and the goals of performing that treatment for our patients. The first goal, or the first principle, is the person is a unit composed of the body, mind, and spirit. The body is capable of homeostasis, self-healing, and health maintenance. Structure and function are interrelated, and rational treatment is based on an understanding of the above principles. So when you look at these principles together, it's a very kind of holistic approach to treating a patient. Now, osteopathic manipulative treatment is a hands-on therapy that is designed to diagnose and treat injury and illness, and to encourage the body's natural tendency towards self-healing. As a DO, you get a lot of specialized training in it. We did about 4 to 8 hours a week for at least 2 years, on top of multiple rotations. And then I have been able to continue practicing throughout my training. We do receive specialized training in musculoskeletal system, the interconnectedness of the nerves, muscles, and bones. So this is the AOA, who is our board, their general statement about osteopathic manipulative treatment. So some of the known benefits of OMT are decreased chronic pain symptoms and reducing the use of medication, improving symptoms of low back pain, managing migraine episodes, decreasing symptoms of migraine headaches, reducing pelvic girdle pain, low back pain during pregnancy, improving joint pain and stiffness, improvement in management of COPD. There are many more illnesses and disorders that we treat. This list kind of came together as some of the most evidence-based. It is pretty hard to study OMT, as it is done through a practitioner, which can vary from person to person. So next. So why OMT for patients with spinal cord injury? Oh, it's not saying it. The main part that I go after is the nociceptive pain we have here when we talk about our identification of spinal cord injury pain and the phenotypes that we have developed over the years. All of our patients have pain. I think we need to do a better job about differentiating which types of pain they're having. And I use OMT in my practice to help me differentiate some of those pains and come up with a better treatment plan for addressing them. There has been some research done on OMT for pain for individuals with spinal cord injury. In 2011, there was a clinical trial. We looked at 3 groups of individuals. The first group was treated with only medications, which happened to be Lyrica and Celebrex, so targeting both that neuropathic pain component and that nociceptive pain component. The next was treated with just OMT, and then the third was treated with both. They found that 24% of the patients that were treated with just medications had an improved pain perception, whereas those treated with just OMT had a 16% improved pain perception. However, they found that it kind of leveled off at about 3 weeks. I think the more important part of what they found in this study is that the combination of the 2 approaches yielded a significantly better pain relief in both patients with nociceptive pain, but also pure neuropathic pain. This is particularly interesting to me because I don't tend to use OMT for neuropathic pain. So it's kind of something I enjoyed learning about. There are multiple treatments or types of treatments for OMT. There are 40, in fact. On here, I've listed the 5 most common. They happen to be the 5 I use the most. The first is muscle energy technique. The second would be counterstrain. Third is high velocity, low amplitude thrust. And so that one in particular is similar to a chiropractic technique. So you do kind of get that pop sensation when you perform that technique. I do not use it very often in the spinal cord population. Craniosacral and myofascial. For people on the call, if you are not a physician and you maybe are a therapist or a different practicing clinician, there's a lot of crossover with these techniques. Many of the therapists and individuals who practice manual therapy will know that they use muscle energy technique as well as counter strain, usually called strain counter strain, as well as a myofascial technique. So with CMS guidelines, we have 10 types of somatic dysfunction. So when you're diagnosing someone to receive an OMT treatment, you want to give them a diagnosis. And the diagnosis we give is called a somatic dysfunction, so a disorder of the muscles. And we do it based on body region. So here we have the 10 regions that I get paid for. And first is head, cervical spine, thoracic spine, lumbar, ribs, pelvis, sacrum, upper extremity, lower extremity, and abdomen. I'm not going to really talk much about the abdomen today. There is a whole component of manipulation for the viscera. I don't happen to do it, but they are looking into it for neurogenic bowel at Cleveland Clinic in a clinical trial right now. So some of the common dysfunctions of those particular regions that we see in individuals with SCI, you'll see a lot of rotations of the sacrum and the pelvis. And this can be generated from multiple different causes, whether it's actual trauma, so the trauma that happened to them in order to get their spinal cord injury. It can be having to do with positioning, so positioning while they're in bed during their acute stay, positioning while they're in bed during their acute rehab stay, can happen to do with their type of wheelchair. All of those things can cause rotations in the sacrum and the pelvis, as well as spasticity and muscle length discrepancies, whether they're short or long. The next is scapular dysfunction, and this is something we kind of all know well in the spinal cord injury community. And that's kind of some of the bread and butter I do for OMT here, and something more Ahmed and I will talk about at the end of the presentation. The next is rotations of the cervical, thoracic, and lumbar spine, and similar, driven by asymmetry within the spinal cord injury itself. So having one side weaker than the other and or one side more spastic than the other, you tend to compensate, and that will cause rotations of your spine. Next is you can see variation in the ribs. So once again, you see that a lot with trauma. So you can see, having ribs not move appropriately and becoming dysfunctional from the trauma itself. Can be dysfunctional from lack of innervation, and so they're just really not stretching out as much. And then as that recovers, those muscles in between are still shortened. So it becomes it still continues to be hard to take that full breath. And then also you will see dysfunctions up in the upper ribs as well because of accessory muscle use and high levels of tetraplegia. You also can see restrictions in the diaphragm, and a lot of that comes just from lacking that full breath. And so you will end up with kind of a tense diaphragm that you can use OMT, specifically muscle energy, to go ahead and stretch that diaphragm out. And patients will say they get a much fuller breath after you do that, and it's much more comfortable. Myofascial dysfunction, that's pretty much the whole body after experiencing trauma and really feeling how differently your body moves after that. You have a lot of myofascial dysfunction just because your body's not moving as it did, or even based on positional and things like that. You also can have the pronated and supinated forearms. The reason I talk about this is because I treat it quite frequently. It helps a lot with pushing. So really, and also driving a power wheelchair. So really making sure you have that freedom to both supinate and pronate your arm to be able to use your hands, what function you have of them effectively to use for wheelchair propulsion, and being able to drive your power wheelchair. So I wanted to present, I have 2 cases of patients I have seen in clinic who have had good results with OMT, but also can kind of give a large spectrum of the type of function I see and the outcomes I have that way, but also kind of give a really good patient experience so that you know if you are referring to someone who is an osteopath that manipulates OMT, or if you are a patient or a person with a spinal cord injury on the call today, you might know what you're in for. And so we're going to go ahead and get started with those. My first one is a 39-year-old female with history of Brown-Séquard syndrome from a motor vehicle accident in 1998. She presented with decreased function due to posterior pelvic pain. So this patient, she came in, she was actually coming in to just establish a spinal cord doctor. She hadn't had one for basically since her injury, and she happened to come in and see me. She stated she had been really active, really, until up about 2 months ago. She was able to perform yoga, run, and lift weights. She was now struggling to get up off the floor after playing with her young children. Her pain occasionally radiated down her leg, especially when she laid in bed at night. It was a 4 out of 10 pain, and it was located in her right posterior pelvis. She missed her tightness on the right side. She was currently only taking naproxen, and she was having no medications for spasticity. Okay, so this goes a little bit into in-depth how DO uses their hands-on techniques to diagnose dysfunction throughout the body. This is a little bit more detailed than a lot of you need to know, but I think it's a good idea to understand the process. So for the pelvis, you're using bony landmarks to determine if there is rotation or shear in the pelvis and or in-flare, out-flare. So here we use the ASIS anteriorly and the PSIS posteriorly. And for the sacrum, it gets quite a bit more complicated. Here is an image of the sacrum, and you can see the PSIS is there. You slide medially, and you will feel a sacral sulcus. And then you will move about 2 centimeters, 3 centimeters inferiorly, and you will hit the ILA, the inferior lateral angle of the sacrum. And using the depth that you are feeling with your fingers, you can determine how the sacrum is rotated. The sacrum tends to be quite complex because it has multiple axes of rotation. So it does take some time to get used to how to diagnose this. In the bottom left-hand corner, in case you're curious, that is the shorthand that all DOs will use to determine the rotation of the sacrum. Talking about D is for deep, P is for prominent, and the plus side is the side that they're having issues with, and talking about rotation that way. So for our patient, she had a left-on-left sacral rotation, which is also called a forward rotation. She had a right superior shear of the innominate. So the innominate, we're talking about just the pelvic bones themselves, not including the sacrum. This is really common to see in an individual who has a leg length discrepancy. It's also very common to see when people fall down stairs, because they'll hit the bottom of the IT, which will shove the pelvis upward, and it actually is quite painful, and it's something you can relieve the pain of readily in clinic with a manipulation. Then she also has a L5 rotated right side and left. So your whole body is connected. So when you have a rotation somewhere, it's going to translate. And so when you have that rotation in the sacrum, you're going to expect to have a rotation in the lumbar spine as well. It's typically opposite. So for our first treatment, we're going to talk about muscle energy. It's the use of voluntary isometric contraction against an unyielding counterforce applied by a physician in a specific direction. It's followed by a post-isometric stretch to lengthen, shorten, contracted, or spastic muscle. This is pretty much one of my go-to treatments. We see patients with spasticity all the time, and we see patients with shortened muscle all the time, just from lack of range of motion of their joints and spine. Some indications are edema, muscular pain or shortening, limited range of motion, headache, TMJ, cervicogenic headaches. There are some contraindications. The main one, I think most of them are obvious. The main one you think about with spinal cord injury is that severe osteoporosis. So, really monitoring bone density as an outpatient physician kind of lets me know what techniques I can and can't use for certain individuals. So I wanted to kind of give you an idea of what a treatment would look like. So for this patient, the superior innominate shear, where that whole pelvis is shifted upward, you go ahead and have them lay flat on the table. I actually am very lucky, and I have therapy mats in my room. And so I am able to have patients either transfer themselves or transfer with a Hoyer onto a therapy mat. And so I have the opportunity to actually do a lot of these types of manipulations in a supine or prone position. I also can do them in power chairs. I have a lot of patients who prefer not to transfer, and they get amazingly flat, and you can kind of make them work. And I've also learned to do just a lot of things in the seated position, kind of for ease of treatment. So for this one in general, you are going to go ahead and abduct the leg. So bring it out, that gaps the SI joint, and you internally rotate. And now the piece of the muscle energy technique that you do is I would be pulling down on the leg inferiorly while the patient does a hip hike or pull against me. They should not win. It should be an isometric contraction. And then you tell them to release and you pull. So it's really taking advantage of that moment when a contraction turns off and muscle fibers relax, that you're able to gain more length in that muscle and create that opportunity for correction and the dysfunction in the pelvis. So you do it 3 to 5 times. The next one would be for that sacral torsion. I kind of have these in reverse order. In treatment in general, I always start with the sacrum and move to the innominates. So for this one, the patient's going to be lying on their side, rotated with chest down, and their knees and feet are going to be dropped off the table. You're going to monitor the sacrum because you will actually feel it move and come out of the rotation. And then you're going to push down on the legs as they push up against your hands and provide that same stretch. You do it about 3 to 5 times. So for this patient, she had a really amazing results. So I actually treated her on her very first appointment with me, and she had an 80% reduction in her symptoms, and they were maintained until the next time I saw her 2 weeks later. At that point, she was able to return to more activity. At that point, she was just walking and doing a little bit of strength training in the gym. I was very fortunate to get to see her last week, and I asked her, because she didn't want me to take a video of her gait, because that's what I wanted to do, if there is anything that I could say about OMT and how it's affected her life. And this is what she said. OMT was a game changer. It allowed me to return to everything I wanted to do. And for her, she is a tremendously active mom, and to go from not being able to get up on the floor to getting back to working out was really helped her move past that kind of barrier of pain and get back to function. I also, when I do OMT treatments, I try to look at the cause of why a dysfunction is happening. So for her, it was her spasticity and a little bit of lack of mobility and exercise. So we actually went ahead and did Botox injections following her second treatment to her right hamstring, her adductor, her plantar flexor, and her posterior tibial. After that, she had an amazing outcome. She was actually able to perform yoga positions she had never done before, and she was able to resume running, which was actually one of her passions. And so it was a really great outcome. She remains pain-free with a combination of monthly OMT and Botox every 12 weeks. So this is kind of one type of patient I see, which is an ambulatory and complete spine. So the pretty much exact opposite would be this gentleman who is lovely. I actually saw him while I was in fellowship. He's a 68-year-old male with history of C4, ASA, tetraplegia, secondary motor vehicle accident in 2005. He presented to clinic with neck and shoulder pain. His pain was about a 6 out of 10, sometimes a 10 out of 10. It radiated down his neck, shoulder, and occasionally into his arm. He was currently taking 8 tabs of 5 milligram oxycodone, and he really disliked taking it. He just said, you know, I feel like a zombie. I'm sleepy all the time. He just wanted to get off of it, but the pain was so severe that he took it anyway. His big want for the outcome of OMT was he was a lifetime New York Jets fan, and his biggest wish was to watch a game with his head straight up, because he hasn't been able to since his injury 15 years ago. So this gentleman had been ventilated for a long period of time, and he was definitely stuck in this posture with the shoulder up and then around. So when I met him, he was about here. And so he did not enjoy watching football out of the corner of his eye. So now we need to diagnose what's going on with his cervical spine as well as his shoulders. I do start with the cervical spine here. I just wanted you to appreciate, you know, the articular pillar or lateral mass, whatever you choose to call it, of each vertebral body. And we palpate those and see if there's any rotation, side bending, and then also see where they kind of want to be. The other thing you can do, which is marked on this slide, is look for tender points along those spines, and that's what those kind of letters mean there. And then in terms of the shoulder, you know, observation is the biggest. You know, you can walk in and learn a lot about how someone's shoulders just by looking at it and then watching them use it. So watching them reach overhead, watching them reach forward, looking at the asymmetry between the two arms, but then also kind of, you know, do your passive range of motion and really feel how the arm moves itself, like what's going on with the humerus, but also know how the scapula moves as well, because it is the concert of the two that can really contribute to shoulder pain, as well as what's going on with the neck, because you do have that connection of the scapula and the trap going into the neck as well. So diagnosis for him, I kind of gave it away a little bit, but he was definitely side bend over here left, this way. His SCM was shortened, his trapezius was shortened, his rib was inhaled on this side. He also had his scapula was elevated up here, and then he was internally rotated with his humerus and protracted. So for his treatment, I started off with counter strain, which is a little bit more of a gentle technique. I like to use it quite a bit when there's a lot of chronicity in the tissues, so they feel very stiff and shortened. If you go in right away, they tend to stiffen up on you. So this can also happen in acute conditions as well. It's an indirect technique for non-radiating tender points, like those ones we saw in that picture of the spine. And it involves passively moving the patient into a position that decreases tenderness of the point by releasing tension of the soft tissues. So you're monitoring the tissues and reevaluating for tenderness, but also feeling them relax some. You need to have like a little bit of play in the tissues to be able to make any gains on length. Indications, so as I said, you know, you can do it in acute conditions or early chronic whiplash. There are no contraindications with this one, which is nice. You can really use it as a modality at any time. The times it's hard to use are individuals who can't relax. So if they're constantly stuck up, there's no way you can do counter strain on them, because you will never know what the tissues are doing because they're constantly firing them with their kind of anxiety. All right, So for him, as I said, it's kind of my first technique to soften the tissues. I'm sorry, my picture's a little bit grainy there, but what you would go ahead and do for him is since the back of the neck is tender and tight, you're going to extend back to allow those muscles to shorten, and then you're going to rotate towards, for him it was this way, rotate towards the side that it's side bending, and wait for those muscles to relax. And once you get that, you're able to have a little bit more length to play with. And then I would convert over to a muscle energy technique. And here I did the trapezius one because it's wonderful. Everyone really enjoys it. And so that's doing muscle energy for the trapezius, which he had. So you're going to be pulling away from the side that is restricted and pushing down, and then doing that same isometric contraction with the shrug of the shoulder up in, and then continuing to stretch this way. And it gives a lot of really nice length to the trapezius, and it does give really good range of motion and pain relief often. So the second technique I used for him, and this is what I start with for the vast majority of shoulder pain, is myofascial. One is a direct myofascial technique, which engages the myofascial restrictive barrier. And you're kind of providing this constant loading of the tissue, and you kind of keep changing your position in constant force and feeling it unwind, but you're going into the restriction, so it's direct. Indirect, you're going away and you're kind of spiraling away from the tightness. Both can help free up that myofascial dysfunction. So indications, obviously for myofascial connective tissue involves supportive tissues. If people won't tolerate other techniques, and then all soft tissue or joint restrictions. They really only have relative contraindications. It truly is for DOs. I know other specialties do a little bit more of an aggressive treatment. It is a really nice treatment that gives a lot of pain relief in general and can really start to help you diagnose what's going on underneath that myofascial layer and looking more at muscle length there as a reason for the somatic dysfunction. So here, these are I put all my favorites in here for you guys. So this is my favorite one for the shoulder. And so you're contacting that lateral inferior edge of the scapula with one hand, and then you are depressing the scapula with the other hand over the shoulder. And you're really trying to find different planes where that you can have the muscles that are attached to the scapula relax. So whether that's engaging it into the restrictive barrier, where you're hitting a hard stop and just kind of trying to kind of push fast into it, or going the other direction. I really like this technique as my starting one because it gives me like really good hands on the patient, and I can feel maybe what specific muscles I want to target afterwards with like a muscle energy technique. So often for spinal cord, we really have shortened lats and shortened subscapularis and shortened pecs. And so you can kind of feel how those muscles are playing into the dynamics of the shoulder when you're able to do some of these myofascial releases. The second one is a pectoral release. And this one I actually teach to a lot of caregivers because it is a really great way to stretch the pec out without putting a lot of strain on the shoulders. Because usually everyone gets taught kind of this like iron cross, which can put a lot of anterior strain on your shoulders as you come back open like this. And this one, you're kind of doing that more pull backwards, and you can tilt back in your chair and really get a nice stretch that way and relieve some of the tension and myofascial restrictions in the chest. So for this gentleman, we were able to decrease his oxycodone to 1 to 0 per day. And he was very ecstatic to watch the jets for the first time in 15 years with his eyes parallel to the field. So I wasn't perfect. We got him to about right here with his head, which he was very happy about. It did take some time. He had significant shortening in his neck musculature. It was not spastic. It was just shortened due to positioning over the years. It took multiple visits about every 2 weeks, times 8+ visits to get the above results. I did end up sending him back to therapy to go ahead and continue working on strengthening, specifically on the opposing side that had gotten so stretched out over the number of years, to help maintain his correction. Also, looking at the reason why some of these things happen, I did some adjustments to his wheelchair. His right armrest was actually too high, so his shoulder was driving him this way. And he also liked to hide his wallet under his right elbow for some reason, which also contributed to the problem. So I had to kind of break him out of that habit. So to kind of wrap up here, I just wanted to give you kind of other examples or other times I find OMT particularly useful for patients with SCI. First and foremost, I find it exceptionally useful after Botox injections or ITB pump implantation. I recently had someone implanted who was already getting kind of leg length shortening, some scoliosis happening. Her pelvis was fully tilted, and also she was having a lot of inflare coming in her pelvis. And since her pump placement, we've actually been able to make some ground on those dysfunctions. But if she didn't have someone going in and working on the length of those muscles, you're not going to have a change in position, even if you have relaxed muscles, because you need to work on the length. It's not just the tone. And the same thing with Botox. The next I would really recommend, and I try and do for my patients, is incomplete ambulation or incomplete injuries with ambulation. So as we know, most individuals with spinal cord injury are very asymmetric. One side's stronger than the other, spastic than the other. And so really working on getting their pelvis and low back aligned while they're learning to walk again and strengthening those lower extremities is very helpful in maintaining a good mechanics in the pelvis and the low back. And so I find this really helps with a lot of the low back pain you will have your incomplete injuries who are ambulating have, if you really kind of dial in that pelvis as they're gaining strength. I started treating OMT actually through adaptive sports. I worked with wheelchair rugby. And so I would say, if you have any adaptive athletes that are having issues, having that opportunity to have some manual therapy or OMT done to help prevent injuries is really important. I do try and see patients after a recent hospitalization. As we know, the care is different when you are in acute hospitalization. When you're at home, you may not get as much range of motion, transfers are different, mobility is different. And so going in and kind of doing a nice once over to make sure everything's nice and aligned before they go back to kind of get back into everything and work on their conditioning. As I mentioned, with the superior shear, happens really commonly after a fall. So if there's falls, really making sure the pelvis and shoulder are in good alignment. Wheelchair positioning in a new wheelchair. A lot of patients will have pain associated with that. So looking at, okay, now we've done all the right things for the wheelchair, but they're still having pain and they're uncomfortable. It may be because their body is stuck in a dysfunction from a previous wheelchair or previous position. So looking at that and seeing if you correct that dysfunction, if then their wheelchair fits a little bit more appropriately. I have a really good instance of this. I had a patient come recently who had all this work done on the back of her chair, manual chair user, and she's like, I don't get it, like right here, it hurts me every time. And she actually had a rib out. And so I put her rib back in and she had no pain, and it wasn't the wheelchair at all. It was just because she had this dysfunction. There's a lot you can do for respiratory. So after prolonged intubation, ventilation, part of it's kind of what we saw with my last patient. If someone could have worked on the length of those muscles before they got so shortened, either through acute rehab or for the outpatient rehab or outpatient experience, and getting him more midline, that would have been helpful. And then also working on making sure the intercostal muscles are staying lengthened as well as the diaphragm. So and that is it for my part of the presentation. Thank you so much for listening. Here is the link if you want to find someone who does OMT near you. It's there.
Thank you, Dr. Miller. Thank you for a great presentation today. And as people are typing questions into the chat or the Q&A, I'd like to take this opportunity to introduce our discussant, Ahmed El-Yamani. Ahmed was injured in March of 2017 in a motorcycle accident, which resulted in a T9 AISA SCI. He owns and operates an automotive repair business, sorry. He remains active by participating in the ABLE program and Fit for Recovery in the community. He has been working with Dr. Miller to help alleviate his right shoulder pain utilizing OMT over the last 4 months. Ahmed, thank you for joining us today. We look forward to hearing your thoughts.
I mean, when I seen Dr. Miller, I was having a hard time using my manual wheelchair. And I remember the first time, it was only 15 minutes, and she told me after she did the work that it didn't feel like she did anything, but she told me, you're not gonna be sore tomorrow. When I left, I was able to use my arm again. I mean, I was just, I couldn't understand how, because it didn't feel like she massaged it or anything. She just touched, a few muscles, by the shoulder. And the following morning, when I woke up with a sore neck, I understood that, she was exactly knew what she was talking about. And I've been seeing her every 2 weeks now, and the shoulder been functioning. I mean, compared to when I started 4 months ago, I had a hard time just, using the manual wheelchair myself. And I was scared because I didn't want to go to a power wheelchair. So, she did a great job. And, it sounds so simple, but it's amazing that not too many people use that, technique to help.
All right, thank you so much for sharing your experience with us today and for joining us today.
Yeah, you're welcome.
Dr. Miller, we do have a question in the Q&A. So someone asked if you could talk a little bit more about insurance reimbursement for OMT and if it's always covered.
In my experience, it is always covered. It is part of SCIMS guidelines and Medicare. So Medicare pays for it, which means the vast majority of insurances will pay for it.
Great, thank you. I don't see any other questions in the chat at this time. I'll give maybe people another minute or so. Oh, here we go. Somebody says, what are the differences between OMT and chiropractic?
Okay, so some of it comes down to diagnosis. So chiropractors often use x-rays to diagnose. They'll do a full set of films when you see them. They also use their hands. I only use my hands for my diagnosis. And I also focus on things beyond the bones. Usually chiropractors focus mainly on just the bones themselves, but DOs will do both. You're looking at your bony structure to tell you their diagnosis, but then you're going in and treating the supporting structures around them to provide the correction. So those are kind of the two differences.
Great, thank you. All right. I do not see any other questions in the chat or the Q&A at this time. Oh, one just popped up. Every time I say that, another one pops up. So what is the timeline for treatment and how long do people typically see you?
Yeah, so it depends on the patient. I would say, for someone who has a lot of function and I'm treating them and they're able to do stretches and exercises regularly, you usually have a little bit of an acute phase at the beginning where we're seeing each other about every 2 weeks. And then it becomes more of a maintenance of once a month. But for individuals who their dysfunction is from how they're using their extremity, for instance. It may have to be pretty frequent just to maintain the correction. So it depends on the person, but also what you're able to do outside of the treatment to maintain what we do. So like Ahmed knows when he starts to slip back that he needs to do the stretches that I gave him to help alleviate pain. But you know, if you're a higher quadriplegic and you can't perform those stretches yourself, or you don't have a PCA that can help you, then you might see me more frequently because I'm going to have to kind of keep doing it. So the hope is to get to a maintenance phase of more like once a month, or once you have a recurrence. For instance, my first patient I talked about, it took 2 months off for a brief period where she was doing fine. And then she actually ended up getting COVID and having to really go backwards on exercise and not being able to exercise. And so then she started having the pain again. And so she came back in. So it's a little bit just dependent on those things.
Great, thank you. And then someone else also asked, how does your treatment pair with exercise? Should there be an exercise program paired with this treatment, or should there be a rest period?
Exercise, always. Always exercise. No, because that's what keeps your tissues healthy, right? Maintaining that really good blood flow through all the tissues and stretch, I think we really underplay the importance of stretching and individual muscle strengthening in general. So yes, exercise. Even if you exercise, you will likely be sore the next day. Some people don't believe me, and then they find out. And that's just because I did a lot of work, and those muscles are sore after, and it usually goes away after a day or two.
Great, thank you. And thank you, Dr. Miller and Ahmed, for joining us today. We really appreciate your presentation. And thank you to all of our attendees for today's Grand Rounds. If you have any other questions, please feel free to reach out to Dr. Miller directly. I don't know, Dr. Miller, if you want to put your email in the chat, if you're comfortable doing so people could reach out to you with any questions. And then the recording, great, thank you. We will
the most important thing is my name changed. So it's Dr. Durazmi, so that's what I'll put in the email of the chat. Try not to get too confused.
Okay, thank you. As we mentioned, today's webinar Grand Rounds is recorded, and we will post it soon on our MnSCIMS website. As a reminder, please see the chat for information on how to obtain CME credit for attending today's Grand Rounds. And at the end of the webinar, a brief 3-question survey will pop up on your screen, and we would really appreciate your feedback. We also hope you can join us for our next Grand Rounds on Thursday, October 6th at noon Central Time, where Dr. Leah Hansen will present intranasal insulin to improve recovery following cervical spinal cord injury. Thank you everybody for joining us, and we hope you have a great rest of your day.